Hey guys, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over the $1 Million Minute, kind of what helped us get to the $1 Million mark and beyond. So this is a day, I'm recording of a Tuesday. So there are 23 appointments, 20 minutes opening. I had one cancellation, so there were 2 openings, and so I guess the total will be 22 patients. So the first patient was just so you know, this was a day that my scribe was at a funeral. So occasionally this happens. I want to talk you through this. I have a replacement scribe. So my scribe is named Murali, and my replacement is Krishna. So Krishna is very good. He's a kind of a managing scribe that manages others. I have to check my notes a little bit better, and I have to kind of correct him and show him, but it works pretty seamlessly because it's the same phone number that I log into. I didn't have, it's sometimes hard with these links, with these team links, so I couldn't really show on my screen, but I did make some corrections, simple things, but you just have to check it a little bit more attentive whenever you have a replacement scribe, and I feel like I can't go as fast with patients, so that's a little bit of a struggle. Also, I wanted to let everyone know there was not a clear place of putting my Swift information on that. I know many people struggle with these technologies. That's what I'm finding, like Shockwave and Swift and ultrasound. And so I put a lot of resources that can help you not only, it's not so much learning how to do it, it's more learning how to incorporate it into your practice, how to explain it to patients, and how to like increase the amount that you do in your office. So I put some of those Swift resources on the bottom of that page on the main page on Podiatry Practice Mastery. So if you have a Swift and you're not using it, so that's one of the big struggles I find. A lot of people own stuff and they just never use it. And I think a lot of times we don't use it because we don't know how to use it, we don't feel comfortable using it, and we don't know we don't have it into an actual system in our practice and when we use it. So that's something. If you have a struggle with that, shoot me an email. I'd be happy to let you know if you have this expensive stuff sitting around and not using it. Reach out to me. Okay, I'd be happy to help get on a call with you. Okay. We had an office meeting this morning. We tend to do our office meetings. So the staff does their meetings once a month on the first Friday. So that's why we have a half day on that day, just the morning. And as doctors and manager, we have a meeting most Tuesday mornings. So we had one today, and it was all about staff. I don't know about you. I've talked to other doctors. We struggle with staff kind of leaving, staff not being professional, trying to find other staff. So it's kind of a revolving door issue and struggles with staff. So just kind of letting you know the reality of what my practice is like. We're still struggling with it. We're still doing well, but it's hard to find staff that'll stick around. Okay, next, first patient of the day. This was a patient that got the fungal kit. So just a reminder, usually I'm doing a nail sample and then 3 weeks later going over the nail sample. But for a lot of patients, I'm saying now, hey, if you just want to skip the nail sample, we can just go right into the process. And I'm finding a lot of patients are just preferring that. I'll tell you, in the future, if I find out a lot of them aren't resolving with the Lamisil, meaning maybe I should have taken a nail sample. But for like this one here, they just got the fungal kit. So what the fungal kit is the Lamisil, the LFTs, the UV light, the shoe spray, and the biotin. So that they got the kit. Just as a reminder, I tend to say this kit is about $200. It's a one-time thing, and it's everything you need for the whole treatment process. So that's what they got, along with and they're going to see me back in 3 months. Another patient came back. This was came back after multiple years. They had a porokeratoma, so someone corrected me, so I'm fixing this. I'm sorry if you don't like the word porokeratoma. That's kind of how I was trained, and I think I just kept it, but it's really called an IPK. And IPKs aren't covered by insurance. So we got a lot of takebacks or not collected money from Blue Cross for those diagnoses. So what I've done when I biopsied them, they've come back either as callus or mature wart. And so my friend made a little joke. So what does that mean? An immature wart would be someone that makes jokes. But so it's a mature wart. And so I feel comfortable when I'm billing those porokeratomas or IPKs doing lesion destruction on them using the benign lesion code and also doing wart on that, because many times when I'm removing them, that's what they come back as. So I'm changing my billing to include wart. And now once again, these I'm only doing like once a year, once every couple of years when they come back. These aren't ones that I'm seeing every 3 months for. Okay, just so you know about that. Okay, next patient was someone 26-year-old girl that came in. She is a medical student. She has Raynaud's on her toes. She has a little bit of a curved hammer toe. and she has a little bit of a tailor's bunion. So I talked to her mostly about shoes, gave her some cute shoes from Anya's reviews and also some running shoes, and she was happy with that. So non-surgical treatments, and then we talked about how we say shoes first and then correct toes second. Next was a patient. This was EPAT number 1 of 6 for the plantar medial heel pain. Next patient was a 65-year-old that came in. I did a nail sample for a possible fungus, debrided a few of the nails, and I'm going to see her back to go over the results. The main reason for this one is she's a little bit older. I wasn't quite sure if it was just a dystrophic nail due to like ingrown toenails and hitting on the shoes, or whether it was a fungus. That's why I did the nail sample. Next was another pre-op Shockwave. So this patient, I'm going to be removing the tibial sesamoid. She has already done Shockwave before, didn't get better. And then for her, I am going to do 3 sessions of Shockwave prior to her surgery to help with surgical recovery. Next patient was a Lamisil follow-up. Everything looks better. I debrided those thick nails, and then no follow-up after. So this may have been a possibly not needed visit. Okay. So this is Lamisil follow-up is where I prescribe and then see them back in 6 months. And this 6-month one might not be necessary because his nails were looking good. And it was kind of a low value type of visit, or maybe having it a visit with my medical assistant might be a better option. Next was another new patient that came in. She had a painful lump on the bottom of her foot. I did an X-ray, I did an ultrasound, and I want to be clear, I can't I can't read my handwriting. So she had something going on there. I think she had some type of a lesion that I removed. That was some bump on her foot, but it was fine afterwards. Next was a 68-year-old female. This was a patient. She had first met cuneiform pain, and she got better with a cortisone injection, but she was concerned as she's being more active that would spur up again. So what I did for her is I did an orthotic. So that was orthotic number 1 for that patient, for the orthotic number 1 for the day. Next was a MVP patient. This was a patient that was 51. She's here for EPAT 4. We did an amnio injection. So I did EPAT first and then an amnio injection, and she already had a cam boot. So this would have been the MVP of the day. Next patient was a patient that did new patient. I went over the whole option for Lamisil. She wanted to start the process, so we did Lamisil number 1 with the kit today for her, and she's going to be back in 3 months. Next was this was a patient that he had left fifth med head bursitis, and he came in dealing with this for over a year. He thought that he needed a bursectomy or bursitis surgery, and when he came in, I recommended Shockwave and amnio. And he is totally asymptomatic, and he was a roller skater, so he wants to get back into roller skating. He was so happy. I did a video on him, so I'm going to put that up on my YouTube page. But he was very, very happy with everything. He thought he was going to have surgery, avoided surgery, and is feeling much better. That was the morning. Afternoon, first patient was 82-year-old, had flexible hammer toes 2 to 5 on the left, and he wanted to have surgery, so we're going to do flexor tenotomies of those because they're hurting on the distal lateral nail edge because they're curving and kind of shifting and twisting, and he's always on them, and so we're going to do those flexor tenotomies in the office. Just in terms of scheduling, I did schedule myself 2 appointment slots for that, so for 40 minutes instead of just 20 minutes because I have to numb them all up, and then I have to cut all the tendons, and I have to wrap them all up with Coban. Next patient was an 83-year-old. She was a kind of a success case for Onifix. So she had kind of a dorsally positioned hallux. It was kind of like one of those where it's sticking up. It was thick. It was ingrown. It was just horrible. So her doctor put her on diflucan, and she's actually still on it. And she is, like I said, 82. Another doctor put her on diflucan, but she kept on it. And the nail was so bad we avulsed it. As it was starting to grow back after 3 months, then I put an Onifix, and now the nail is growing out, and it just looks perfect. It just looks pristine. So I don't really see that often, where a nail is like totally sticking up, is able to flatten out. So it's totally flat. Not sure if it would have gotten flat just with the diflucan, but I think with that positional change, I think the Onifix really helped. Next patient was a 76-year-old that had insertional Achilles tendonitis. I did EPAT number 3. They got another 3 left to do. Next was a 68-year-old patient, new patient, got a diabetic foot exam, had metatarsalgia to the second met head with a bunion. But really, they just want to help with the diabetes and the nails, so they're going to come back to see my nail tech. Next patient was a 40-year-old that had a ingrown toenail, and I did a partial nail avulsion on that patient. Next patient was a matrix follow-up, but also had some heel pain. So he did EPAT number 1 of 6. So I tried it once again. I tried to do the Shockwave the same day. EPAT number 1. So I did Shockwave, radial, and unfocused, because at this office I had unfocused. And then I also talked to him about, like, to prevent recurrence in the future, I recommended orthotics. So he did all 6, and he also got scanned for orthotics today for this patient. So this is a 45-year-old. So that might have been one of my other MVPs of the day. Next patient was a 36-year-old. They got Lamisil number 1. She's an established patient here 3 years ago. Nail fungus, wanted to not do the test and just go right into the Lamisil. So I did the Lamisil with my kit. So she's going to be, that was one where I'm kind of skipping these nail samples. Next was a 66-year-old patient that got established patient office visit, derided the nails, did a nail sample, going to see them back in 3 weeks. Nail sample mostly because they were unsure what they wanted to do and if they wanted to do treatment for the nail fungus, and they wanted to confirm that it was that. Next was a 4th-digit fracture for a 16-year-old that was healing and well. This was a 6-week follow-up, no need for follow-up. So usually my fractures, if they're real simple, I'll do the initial visit with x-rays and do the fracture code, and then I'll see them 6 weeks after to do the second one and last one. So it tends to, I know some people think, they should be back every 2 weeks to get x-rays. I guess if you need the patient visits, but if you're at a phase where you want to reduce your least valuable patients, then you could consider not having them come back. So I think there's a tight line to have them come back or not to come back. Okay, and then I guess the last thing, like I was saying, it was a kind of a harder day because I was training the scribe replacement, but it's really important to have a scribe replacement, and we have to have, like, my scribe kind of needs a good life as well, so take time off, and so if there's a replacement, it makes life a lot easier. Okay, I hope you guys found this beneficial. Once again, those scribe resources, Swift resources, Shockwave resources, they're all on podiatrypracticemastery.com. On the bottom, I put this new, like, super little footer down there where you can get all those. If you can't find anything, just shoot me an email. Love to hear from you. If you find this beneficial, email me. If you have other things that I don't do that you do, tell me so I can help everyone else to produce more and help them get to the $1 million mark. Okay? Once again, the email is down at podiatrypracticemastery.com. Thanks.